Okay. So talking about some of these factors related to endotracheal airways. I like this one. That's a nasty looking laryngoscope, but sometimes the best solution for unruly patients. Paralyze them, intubate them, ventilate them. Let's skip that. So our endotracheal tube has a couple of key features as far as the design of them. First of all, there is a standard 15 millimeter adapter like you would see on pretty much any airway of any kind to attach to any ventilator circuit resuscitation bag, which has a 15 millimeter inner diameter. This is a 15 millimeter outer diameter. There's an endotracheal tube that has a pilot balloon that is a one-way valving system that allows you to insert air in and inflate the cuff. There's depth markings along the tube along with a radio-opaque line to tell placement for a chest x-ray. The depth markings tells you how far the tube has been inserted, distance from the tip. And then there's a high volume, low pressure cuff, which is pretty standardized now in endotracheal tubes, meaning there's a fair amount of volume you put in, but it doesn't generate a lot of pressure against the tracheal wall.
Did you say one-way valve?
One-way valve. You push it in. What it is basically is just a valve which seals it. And as you push inward, the stem of the syringe opens the door and allows gas to go in or out. So when I'm inflating it, I'm going ahead and inflating it by pushing in. When I deflate, I just put the syringe in, deflate it, and pull it back out again. Maybe a one-way valve isn't the best terminology there, but it's a sealed system as far as that is concerned. And by the way, the best syringe to use is not a standard Luer lock syringe. It's a slip fit tip syringe, which I think we have some examples laying around here. It's the stem of the syringe, the tip, is a little bit longer. Sometimes what happens is people will use a Luer lock and try to push it a little bit harder, and it cracks the pilot balloon. And right, that's a slip fit tip syringe. Say that fast 3 times. Not a chance, woman. Okay, so why do we intubate somebody? The classic reasons are airway compromise, so somebody who has perhaps some trauma and their airway is not intact, or they've had a stroke and they don't have full functions of their swallowing and coughing functions. That'd be a need to protect the airway. Might also have that with somebody who has upper airway burns prior to the airway completely swelling and closing off, getting an endotracheal tube in there. The most common one we need is respiratory failure, where there's a need to mechanically ventilate in an invasive fashion and non-invasive ventilation, which we'll talk about when you guys come back, is an alternative. But usually if they're that severe respiratory failure, they're going to need to be mechanically ventilated. Now the key part is don't confuse the need for an airway with the need for ventilation. And this is very common in the ICU. Somebody comes in, a person has a stroke, they're on a ventilator until they're stabilized, and then 3 days later they're still on the ventilator. It's like, why are they on the ventilator? Well, they had a stroke. Okay, they need an airway, but it doesn't mean they need a ventilator. You can be perfectly fine on a trachea, with an endotracheal tube in place, hooked to a heated aerosol or some other kind of oxygen delivery device, rather than having to be on a ventilator. Okay, so they're two distinct things in the process. These are some examples of the airway compromise. Pretty much you got an idea of some of those. We talked about meconium aspiration being an indication, so that you don't have diaphragmatic hernia, be another example. Protection of the airway, both from bleeding and an inability to manage secretions, and then all the things associated with respiratory failure involved. Okay. So here's the patient admitted to the emergency department suffering chest trauma. Patient's unconscious, cyanotic, tachypnic, and blood in her mouth. and pharynx. Breath sounds are diminished on both sides. And why would we want to intubate? There's multiple things there that are pointing to a airway compromise and probably an inability to adequately ventilate somebody. This is an algorithm, again, we talked about before about the universal algorithm, but part of that is if they're inadequate ventilation, managing their airway appropriately. Don't intubate when you have a desire to not be intubated. In other words, a do not intubate order. Gets really cloudy when you start getting into some of the, what's the word I want to use, Nancy? The continuum of interventions where people say, well, we want this done, we don't want that done. Well, we want them to have CPR, but we don't want them intubated. You can't. You know, that's kind of an impossibility. What if I get a pulse back, but I'm not ventilating? What do I do now? Kind of a situation. So, and there are people who have been on a ventilator before and said, never again. I don't care what you got to do not intubate me. In that case, we could try non-invasive ventilation, but certainly not invasive ventilation where you need to have a tube. Some of there's multiple complications that can exist both at the time, once it's in place, when they're extubated, and then even in the after. Here's a list of some complications at the time of intubation. First one, failure to establish a patent airway. Even though you're attempting to intubate, you can't get the tube in place. And even skilled anesthesiologists will tell you there are just some people that are just tough to manage. And those are ones that we have to look at some alternatives often for. Unrecognized esophageal or bronchial intubation. So even though we're supposed to monitor with end-tidal CO2 immediately upon placement, sometimes that is not done, and we miss the fact that there's an esophageal problem where the tube's in the esophagus. All kinds of trauma can end up happening to any portion of the upper airway or even the lower airway. Aspiration of a tooth that becomes chipped off, or the bulb on that's a real good one. The bulb on the laryngoscope blade comes loose and ends up being aspirated. Fun time there. Damage to the airway as far as the development of granulomas or necrotic or ulcers of the tissue. This is really good after lunch, isn't it? Perforation of the esophagus. Certainly any kind of clinical things like hypoxemia and hypertension, intracranial pressure being increased, and the inducement of laryngospasm or bronchospasm, which again are all things that we just want to stay away from. Once the tube's in place, doesn't mean everything's hunky-dory. You can have problems with aspiration, airway obstruction. Accidental extubation occurs especially when you're moving the patient. Tracheal tube fire, that sounds like a real good one to me, I don't know. That occurs with some kind of laryngeal, that's the word I'm looking for, where they're doing cauterization and there's the potential in oxygen environments to create a fire. Problems with the cuff, you can read through those, pretty much anything that can go wrong could go wrong. When they're extubated, and even though that sounds like it shouldn't be a problem pulling a tube back out, if there's still laryngeal swelling present, it could be a difficult problem. I've had situations where the cuff doesn't deflate fully, so as it's coming out, the cuff remains inflated coming through the vocal cords. Can do some laryngospasm pretty easily there. Certain situations, I don't know why you would suture to the trachea or bronchus, but no, that's one you don't want to screw with for sure. And certainly aspiration because of a reduced function in the process. And then after it's been out, there's all kind of other problems associated with long-term sequelae to the intubation process, where you end up developing tracheal stenosis, tracheomalacia, tracheoesophageal fistula. That last one, tracheoinnominate fistula, is probably one of the worst possible situations that you could ever have. The innominate artery runs proximal to the trachea, and you can actually have situations where either the tip of the tube or the cuff erodes through the trachea and into the innominate artery. Not a good scene. One telltale sign, I've never seen this, but the potential is always there, especially with a tracheostomy tube more so than an endotracheal tube. But if you feel the tube and you feel a pulsation, ooh boy, call somebody. That's not a good sign. There's some advantages and disadvantages to the tubes. Some of the disadvantages is that you're bypassing the normal function of the upper airway as far as heat filtration and humidification. So one of the things we're going to need to do is provide for those things. You lose the ability to communicate. At least with the trach tube, you can read lips. Reading lips is real difficult. So you kind of become a little bit better at it, but it's still, especially if somebody does not have English as their primary language, it's awful. Use of a writing board, and I always encourage you to go lie down in bed, hold the board above you, and try to write. It ain't easy. They use picture boards or letter boards to try and the most common things people would ask for, trying to address it that way, but it's a huge problem. You cannot perform a Valsalva maneuver for defecation or urination, so that gets problems. And you lose your sense of smell, because and from that, your sense of taste. Part of the taste function is the smelling of food, and it's one argument why tracheostomy does have some benefit to it, because they can actually get a little bit of a smell of the food, which improves the sense of taste and improves diet. Lots of stuff is needed for intubation, and we'll kind of go, as we go through these, you'll see how some of these come up. Anything I want to talk about ahead of time? Yeah, we'll get through it. Technically two different types of tubes. One that is designed solely for putting into the nose. One which is designed to be put into the oral cavity. Usually there are combination oronasal tubes, so it's not as specific. And by the way, all I'm talking about are the generic run-of-the-mill endotracheal tubes. And Mary will cover, I don't know how many she covers in the fall, but there's a handful of bizarre ones, and probably some she doesn't even talk about because they're only used in the OR. So we're just going to focus on our simple one for now. So some of the components of it. Letter A is pointing to my pilot tube. So it's running from my pilot balloon down to the endotracheal tube itself. My spring-loaded pilot valve that is there, that is used to inflate the pilot balloon. The beveled tip at the very end with what's called a Murphy eye. It's a separate little hole on the body of the tube itself that is present if you ever want to have, or if the tube should ever become obstructed by going against the side of the wall of the trachea, you would have an alternative method by which to ventilate. So it's another way to ventilate through. There's my high volume, low pressure cuff. There's my radio-opaque line that's running along the length of the tube so we can tell where the tube is located on chest x-ray. There's these fantastic markings that are there that say IT for implantation testing, or Z79 for the Z79 committee, and I'll talk about that in a second, like you really care. There's some distance markings, which are important, that are showing the spots from that spot to the distal tip. What the internal diameter is written not only there, on most endotracheal tubes, it's actually written right there. Because a lot of times this is inside the patient, and you're not able to always see what the marking is. This definitely you're able to see. So on the bottom of the 15 millimeter adapter, it's actually embossed in there also. Okay. They're made of a semi-rigid material, typically polyvinyl chloride, although there are some manufacturers that use silicon as a basis for it. It semi-rigid, implying that while it's outside the body, it has a little bit of form fitting. It's a little bit stiff. Once it gets inside, it warms up a little bit inside the body, and it becomes a little more flexible, which is actually a benefit to the patient. The Z79 committee of the American National Standards Institute, sure, whatever you say, Rick. That basically is just a group of people that have established standards for how a tube should be constructed, what kind of features it should have, et cetera, et cetera. But if you see Z79, that's what it's talking about. Um, and the name actually is no longer ANSI. It's now the American Society for Testing and Materials Standardization Group. And the IT stands for implantation testing, and it means that the material utilized is not toxic to tissue. The implantation testing was actually, for those who care, I believe it was rabbits. They put the plastic in their skin and saw if any damage to the skin occurred. That's a job I'd want to have. Not. But these are some of the things that the 79 guidelines means. You have to have certain performance testings as far as strength of the tube. Has to have a 50 millimeter adapter. All adult tubes have to be a certain distance. The Murphy eye has to be a certain bevel. Common sense stuff that just basically looking for safety as far as that tube properly functioning. Just as a reminder on the adults, the glottic opening is the narrowest part, and the kid it's the cricoid cartilage, which is slightly displaced, and we'll use that in our advantage because most pediatric tubes do not have cuffs. You can get them, but they're not always in that situation. Usually up until about a size 5.5 or 6, which would be for about a 6-year-old, they're uncuffed, but again, you can get them cuffed. There are certain OR procedures where they need to have a sealed system. But just the fact that that cricoid cartilage is narrowed, that narrowing is sufficient enough that you don't need a cuff to maintain adequate ventilation involved. Used to be a tube called a Cole tube that actually would ram into the cricoid. Doesn't that sound like a wonderful time? Rammed into the trachea where the cricoid cartilage is. Ram into the larynx, I should say. But they're no longer used. Stylet is just basically a plastic or metal device which is placed into the endotracheal tube to allow for additional form fitting so it maintains a kind of a straight line for it. The key part is identifying that the tip of the stylet is not protruding out through the end or through the Murphy eye, that it's recessed back far enough that it won't cause any laceration of the trachea as it's going in. McGill forceps were specialized forceps that kind of look like funky scissors, but they're actually like pliers, in that they grip something and are able to hold it. We used to use them a lot with nasal intubation. We don't do as much nasal intubation as we used to because there's certain complications which are a little bit worse as far as sinusitis developing. But you would actually, in a nasal intubation, grab the tip of the tube and direct it towards the larynx in the process. And it's kind of showing how the McGill forceps is grabbing the tube and pulling it towards the esophagus. I'm sorry, towards the trachea. Straight blades, also known as Miller or Wisconsin. Curved blades, known as Macintosh. Same handle, but varying blades. Preference is, use of one is depending upon preference of the intubator. Makes no difference. I will tell you that on most of the mannequins that you encounter, the straight blade is going to be an easier choice because they don't have a really well-defined epiglottis. Both of them have an indentation on the blade itself that fits into a little bar on the handle, and as you lift it to a 90-degree angle, the light comes on and everything is wonderful. Again, blade type is based on preference. The only distinction is that straight blades have to be used with a neonate because they don't have a well-defined vallecula at all. As far as the size of the blade, using it as the individual's hand as kind of an index is one way. You kind of get an idea that usually most adults will use a 3 or 4 Miller or a 3 Macintosh, and as you go down in size, you go down in age. If the light doesn't work, make sure that it's actually clicked in and it's the proper blade for that handle. Some blades are designed strictly for one type of handle. Make sure that the bulb is tight. Make sure the batteries are good. It may just be that the blade itself is no longer functional and you need to get a new one. or you need to get a new bulb in the process. Ideally, you want to use as large of an endotracheal tube as possible. Pousset's law says that as you decrease radius, you increase airway resistance exponentially. You can, on a pediatric patient, use the size of their small finger, although there's actually a better route to end up going, and that's using their age in years divided by 4. So an 8-year-old would have about a size 6, so on and so forth. Or you can look at this fancy chart, which you'll have available. I don't think I ask you any pediatric questions. So most adults will end up having somewhere on the order of 7 to 8 for a female, 8 for a male, roughly. Is that right, Nance?
Usually 7, 7.5 for female.
7, 7.5 for female. Okay.
7.5
For a male. Okay. When we're going to be doing this process, we're going to want to be able to access the pilot balloons, and one of the first things we do is just partially open the wrapper it's in enough to be able to access the pilot balloon. You don't want to expose the entire tube because you want to keep it as sterile as possible because it is going into the airway. We're going to go and inflate the cuff, verify that the cuff is able to be inflated and doesn't have any leaks. We'll put the stylet in the tube, making sure that it's recessed back from the very distal tip. We'll make it look like a hockey stick as far as its shape, because what you basically want to do is access a trachea that's here and you're coming in here. Having that little bit of bend on it will help direct the tip towards the larynx. You can use an water-soluble lubricant on the tip to help it slide better. Often they'll use some lidocaine anesthetic cream that'll, especially if the patient has any kind of level of consciousness that they're awake, it'll reduce a little bit of the cough reflux as it's going in. How to identify a difficult airway? I would like you to know this lemon concept. I kind of like it. The first thing is to look externally. Someone who is of small stature, very short neck, very thick, muscular neck. Patients with buck teeth typically have a small mandible and makes it difficult to be able to manipulate it. Women with large breasts, and we'll show you a picture of that. Receding jaws, orofacial trauma or burns. Foreign body aspirate is what FBAO stands for. And macroglossia as far as a large tongue. So here we have our buck teeth, and there we have our macroglossia. E stands for evaluate, and this is basically the 3-3-2 rule, and talks about you should be able to fit 3 fingers through a wide open mouth. If not, that mouth may not be wide enough to be able to adequately insert in the laryngoscope and visualize. 3 fingers from the mentum to the hyoid. So here's my hyoid bone. You want to have at least 3 fingers, if not more, if there's a distance there. And then 2 fingers from the roof of from the floor of the mouth to the top of the thyroid. So 2 inches here is what that is talking about in this distance here. If somebody's identified as a high-risk airway, that is truly is an indication for somebody who's skilled in intubation to attempt that. And I've known ER doctors say, I just ain't touching that airway, get anesthesia down here because it's a mess. And the problem comes up July 2nd when all the residents want to, practice intubation because, they're now a doctor. It's like, no, go away. This is not the person to practice on. You need somebody who's got a little bit better airway to manage. And there actually is one anesthesia department I know who, when they identify somebody as having a difficult to manage airway, they'll actually suggest to them that they get a medical alert bracelet saying that they have a difficult to manage airway. Malampati is one way of evaluating. You should know that a class 1 is basically the normal airway, and a class 4 would be an extremely difficult to intubate airway. And what you're basically looking at is you're losing, as the person sticks out their tongue, you're losing the ability to see the uvula and the posterior pharynx. And you can see number 4, you can only see the hard palate. You can't see any of the soft palate or the uvula. Okay, so the first 2 are really not much problem. Class 3 and 4, you start to get progressively more difficulty in intubating and managing the airway. The O in lemon stands for obstruction. Is there anything else that could potentially be a problem? I like that. Impaled objects. That sounds like a good choice. You know, yeah, I got this this metal rod running through my neck. That might be a little bit of a problem intubating that person. I don't know. I'm just going to go on a limb. But as far as broken teeth, as far as blood or vomit in the back of the throat, I told you about my story about the little kid, didn't I? I don't know if I told you about that or not. I'll tell it again. We were called on an ER. Our kid was mentally challenged. It was a Downs or some other kind of neurological disorder where the child had a real. First of all, he was obese, just huge, and actually they had a eating dysfunction where he just wouldn't continually eat, to the point where the parents actually had to put a physical padlock on the refrigerator to keep him out. Well, he came in, and the kid's in obvious respiratory distress, diaphoretic, ashen. This might even be before we had pulse ox. I don't remember now, it's so far ago. And you could just hear the audible, gurgling, and says, this kid needs to be tubed, and his blood gases were horrendous. So because of the kid's physical features, we knew it was going to be a tough intubation, so we called anesthesia down. Anesthesia comes down, gets out his laryngoscope, goes in, looks in the back of the throat, and goes, "Holy shit, give me a McGill forceps." So we got a McGill forceps. He reaches in, he pulls out a pork chop bone. No wonder the kid had an airway obstruction. So needless to say, that was relieved a lot of the problem, although he just still ended up having pneumonia that had to be relieved in the process. So N stands for neck mobility, as far as are you able to move your neck. Someone who has probably some upper cervical surgeries, some laminectomies, that maybe has some fusions of some vertebrae, or has arthritic changes. They don't have as mobile of a neck. They're going to be much more of a problematic. And they actually call this the atlanto-occipital angle. I don't think that you need to know that, but just recognize that movement of the neck is an important component. And that's what the N stands for, neck mobility. So assuming we don't have any of those problems, and it's an individual that should not be a difficult intubation, we want to go ahead and, again, get our personal equipment and gloves and everything else on. We're going to assemble the laryngoscope and verify that it's functioning as well as the endotracheal tube is functioning. We're going to position the patient so that their head is lifted slightly, basically into that sniffing position. So we're going to do this. We flex their neck forward and move their head and move their occiput forward also. If you think about how you smell something, that's the direction you end up taking. Doing that puts you in a better alignment than having in the head in a neutral position. As you place that pillow below the head, you actually bring the head this way, and at the same time, you've pulled the jaw up. So you have a direct visualization through the mouth into the trachea. It's a direct line. And this is just showing another picture of how you can manipulate that axis to make it a much more better visualization. Some of the anatomy that you're looking at there, the tongue, the hypopharynx, the glottic opening, and there's your vallecula where you'll place the curved blade. The whole purpose is basically just pull the jaw outward. Now with that head in the proper position, I got a great shot in. This is what I was talking about, just having a difficult time intubation. Talk about a pillow under the head. About 1,001.
That's also referring to the first one when we talked about the big breasts. Is when you're laying flat, everything kind of goes forward. So when you're very well endowed,
because you're basically trying to pull the jaw forward. All that musculature is being pulled downward by the weight of the upper torso. Curved blade, remember, fits into the vallecula. Straight blade fits into the or lifts up on the epiglottis directly. The one's an indirect, one's a direct. On kids, we're not going to do as much hyperextension because you'll actually make that cricoid cartilage close off more. But since we're dealing with adults at this point, it's not as much of an issue. Pre-oxygenate the patient, suction them. If you feel that the patient may have some gagging and discomfort with placement of the laryngoscope in their mouth, using a topical anesthetic agent like that acetylcholine we talked about previously. Caution in using it. There are complications, but it does have a little bit of a benefit of making it a little more of a, I won't say a pleasant procedure. But often they'll use an anesthetic or a paralytic if the patient's fighting at all. And module C, I think, B or C is on pharmacology, and we'll talk about paralytic agents. We talked about acetylcholine or benzocaine previously. It'll suppress it, though. Opening up the mouth, the laryngoscope's always held in the left hand and then placed into the right side of the patient's mouth, with the tongue then being swept from right to left. On the mannequin that you're going to intubate on, I will warn you, do not sweep the tongue. The tongue, the larynx are all one unit. So as you sweep one, you sweep everything. And you end up with the larynx sitting by the guy's left shoulder by the end of the day. So you can just go midline and go straight up. We're going to lift the handle upwards as if toasting. Imagine yourself being at the bar and you have, okay, I'm stretching it, but just imagine you're at the bar and you have a mug of beer and you're toasting somebody across the table from you. That's the maneuver you want to use. What you don't want to do is pretend you're at the casino and pull back. And using the teeth as a fulcrum, you'll snap the front teeth. And then they call their plaintiff attorney and nobody's happy. Except for the attorney. They're always happy. And if you keep the wrist straight, it's basically just a lifting mechanism that you want to end up doing. Now that is the most ugly looking endotracheal tube I think I have ever seen. Whoever drew this picture for Egan's book really needs to go back to school a little bit. But again, we're holding the blade or the handle in our left hand. We're sweeping the tongue out of its visual field, lifting it, and then you're able to go ahead and visualize the laryngeal structures. And there you can see the tube on the left-hand side, the tongue being swept out of the visual field. I don't know how well you can make that out or not, but you can see the vocal cords, nice white structures located there. This is obviously a Mac blade because here's my epiglottis being well defined. Once we visualize the glottic and the anatomical landmarks, your arytenoid cuneiform cartilages, we can go ahead and visualize the cords. And despite amazing advances in medical science, your patient cannot breathe through his tummy. Ain't that the truth? And by the way, that's upside down. Right? Here's your arytenoid and cuneiform cartilages. Here's your epiglottis. When you'd visualize it, you actually visualize it in the opposite direction. Like that. Okay? Use of cricoid pressure may facilitate intubation. Again, just identifying the cricoid cartilage. On a male, it's pretty easy. Thyroid cartilage is pretty prominent right below it. You can feel the cricothyroid membrane right below that. The cricoid cartilage. On a woman, find the suprasternal notch, slide the finger up the center of the neck. The first structure you'll feel will be a cricoid. Finger and thumb on opposite sides as shown. Push down on the cricoid cartilage. You'll actually drop the laryngeal structures down. The other feature you have is you compress the esophagus in the process. So with the endotracheal tube in the right side, we're now going and we're putting the tube in along the side, not through the channel you're looking at, because then you wouldn't be able to see. You're coming from the right side. You want to insert the endotracheal tube until the cuff is past the cords. Once you get up that far, you've gone far enough. So here he is going and putting it in. And this is just some of the view. You can see the tube. You can see the cuff right here. And as that cuff is going through the cords, once the cuff passes through the cords, it's in far enough. Okay. Oh. What do you think? You go and you look and you see a big hunk of steak. Get those forceps, McGill forceps, that's right. You can attempt a finger sweep, but in many cases it might be more problematic. Best bet is just use something to get it out. Once the tube has been placed through the cords, do not let go of the tube. Notice that's capital letters. That's an automatic failure at your PE if you let it go. Right, Nance? Exactly. Because guess what's going to happen if it's let go? We're going to pull it out for you, and you're going to do it again. So don't let go of the tube, because in some cases, it's a difficult enough airway to manage, and just placement of the tube can actually induce some swelling and make the matters worse. So if it comes out, it's harder to put in the second time.
Actually, I kind of go one step further. When you've got that tube in place, just hanging on to the tube itself, I'll use Steve as an example, if that tube is right here, hanging on to the tube right here is no good. You actually have to hang on to his head and face and tube together kind of thing. Because if you're hanging on to the tube, and I'll show you on the mannequin, it's easier. If you're hanging on to the tube and he decides to sit up as he's laying in the bed and then goes back down, you've got the tube. Oh, goody. He's just excavating himself.
Yeah.
You have to hang on to it. No, you did, because I hung on to my tube. You have to hang on to his face, so when he sits up and he goes back, you still got his face and tube together. Okay, I'll show you that.
You almost got to lock it against the lip,
Right,
so you're
you gotta
holding it
hang on to
physically.
The tube and the face, everything together, so that you're going with your patient at the same time.
Do you remember when Mary was showing how to do a blood gas? You put your hand in their hand, so even if they moved,
Right, everything has to
you're going all together. Same idea here.
Staying hanging on the tube, it's gotta be all together, because you're hanging on the tube, but he just sat up and went back down. I still got my tube.
That's why we use paralytics. That'll never happen.
Yeah, you just wanna make sure, because no, it's, if you're trying
Yeah.
to do the tube exchange, or not the tube exchange, but you're trying to tie your tapes down or something like that, and they decide to wake up all of a sudden, because all of a sudden you're.
It's going to happen at the worst possible time.
Wears
Yep.
off.
So then we remove the laryngoscope, and as you put it down, if you just put it down so the blade folds back up, the light will turn off. We'll save you batteries. And then while, again, holding the tube and securing it against them, we're going to remove the stylet. Now you must hold on to the tube as you pull the stylet out, because another thing will happen. You pull that stylet, it's going to pull the tube with it. So you want to make sure you're holding it in place. We're going to go ahead and inflate the cuff with enough air to eliminate all air escaping during manual ventilation. We're going to call this the minimal occlusive volume, and we'll show you how to measure this directly. But basically, once they stop going, we got enough air in the cuff. We can then go ahead and ventilate and oxygenate them. 30 seconds is the top time it should take you to visualize and place that tube. If not, we want to reoxygenate, reventilate the patient, and try again. And this is one of those times when you really got to be a patient advocate. If the physician's taking longer than that, physically push them out of the way. You can get the tube in longer than that, but the patient's going to be brain dead. And as I always say, we have enough hospital administrators. We don't need any more brain dead people. So then we want to verify proper placement through our various methods. Initially, you can visualization of the tube passing into the trachea should be enough, but we want to have some independent confirmations, looking for symmetrical chest movement, looking for bilateral breath sounds on auscultation, verifying that when you listen over the epigastrum, there's no ventilations going, that you don't hear any sound transmission. Looking at them as far as their color and their pulse oximeter reading. You should be able to pass a catheter through. If you can't pass a suction catheter, that's a bad sign that some other obstruction has occurred. Looking for condensate on the inside of the tube, fog is being there. I will tell you, I've been fooled by a good many of them. Had one where I saw condensation on the tube. shortly followed by a noodle. The guy just had some chicken noodle soup. And it was in his stomach, so don't believe anything. The best way to look is using end-tidal CO2. There were esophageal detector devices. I have not seen those in a long time. We don't even teach them at ACLS anymore, so.
I had never used those before.
Yeah.
We have them here that you can take a look.
It's basically a big syringe or a bulb, and you put it on the end of the endotracheal tube, and if it inflates, it must be in an air-filled chamber. Problem is, if you've been doing bag valve masks for any length of time, your stomach can get air in it, and you can get a false positive with it. So that's not the gold standard. This is what it kind of like looks like. End-tidal CO2 is the gold standard and is now should be used on every cardiac arrest, not only for verification of the endotracheal tube placement, but also for assessment of effective cardiac compression. So most of the time now we should be using a capnograph, not just that colorimetric device. Although they are always good because they went from purple to yellow. Big Bird good, Barney bad. Kind of an easy way to remember it. And this is just basically showing that. The problem was you can't tell what the actual CO2 value is. All you know is that it's okay because it's changing colors. It's not the best mechanism to utilize. And normal end-tidal CO2 should be somewhere around 3 or 4%. So. Placement should be somewhere in this area, 21 to 23 for a male, 19 to 21 for a female. So roughly 20, 21 is a good depth. Nasal we're not going to worry about because you're not going to use a nasal tube with any degree of frequency. This is for informational purposes only. We talked about neonates. Their weight in kilograms plus 6 as far as the depth. For pediatric 12 plus their age divided by 2. I won't ask you that though, so don't worry about it. Chest radiograph tells us the depth, does not tell us if it's in the proper tube. A tube placed into the esophagus will look exactly the same as a tube placed into the trachea on an AP chest x-ray. So we're going to go ahead and use it for depth, but if you truly want to know if it's in the trachea, you would need a lateral neck, which we're not going to do. We're going to verify in our other fashions. So you can see where the carina is located, and can't quite see really well on that picture, but you can see where the tip of the endotracheal tube is, and it's recessed above the carina. We want to see it somewhere about, this says 3 to 7, I'll even go 3 to 5 centimeters above the carina, roughly at about T2 to T4. So the carina's about T5, so you want a little bit above that. Also can use the aortic notch or aortic knob as a kind of an indication. Yes, I love this. I just ran across this one. Intubation always occurs at table height, so never try to do it on the floor. You talk to any medic and they'll tell you. Yeah, that's fine. You talk to any medic and they'll talk about intubating somebody on the ground, and it's not fun. Actually, somebody was showing me one of the easiest ways is to intubate somebody who's sitting up in a car. And I'll show you that if you want. So it's actually a whole lot easier than you would think. Okay, good to go. Yeah, patients are always nicely found on a bed, and there's no problem. Not. Securing the airway, you want to end up having it secured in a neutral position. This is really important because there's going to be a bit of manipulation that goes on of the patient's body position as time goes on. Now, this is an important fact to remember that flexing of the head moves the tube down. It seems opposite from what you would think. Flexion down moves the tube down. Extension moves the tube up. Okay? So you want to make sure that it's in a neutral position to start with. Because what ends up happening is, guess who comes into the room to verify placement of the endotracheal tube? Who's going to come in the room? Radiology, right? They got to put a plate behind the person's back. So you want to make sure the head's in a neutral position when they take the film. We're going to secure it with some kind of device. A lot of times now that we're using more and more of the prefabricated harness devices. We used to use waterproof tape a lot more. Umbilical tape is kind of interesting. Umbilical tape is actually a cloth. They used to use it to tie off umbilical cords back in the old days. But there's one site I know that still utilizes it. And it's really great when you got somebody who's got this big biker with a big burly beard and you want to get that tube tied off. You can actually just tie it behind their head and make a little bow, and it actually holds quite well in the process. And if it gets wet, it's not a problem in the process. But more often we're using these prefabricated harness devices.
That they're making you move the tube every 4 hours.
You can still move it.
Right, but redo it every 4 hours.
Yeah, yeah. That last statement, good luck with that one. I know that's one of Mary's pet peeves, but I can tell you it's done all the time.
It is done, but you can do it, especially with the prefabricated one, you just tape it to
The side of that process, yeah.
as long as they're-
So this is just showing how the tube in the neutral position, where the tip of the tube is in the cuff, and you can see that by flexion you push it down, and by extension you pull it back up. Simple enough movement, but that 4 centimeters or 2 or 3 centimeters moving downward or upward could actually put it into one of the bronchus or pull the tube out entirely out of the trachea. So we're going to use some kind of a device. This is one where you actually have the ability to slide the tube from side to side so we can go from one part of the mouth to the other. This is showing some securing it with some tape. Nasals are a little more problem because you don't have as much tube to grasp onto to hold it into place. This is just showing one of the methods that is utilized for using tape. Putting a piece behind that is basically this is double back tape so that it doesn't stick to the back of their head and pull their hair out. But this part is still adhesive in the process. And showing somebody with a beard, which are always challenges to be able to secure. And this is the little devices for neonatal. You can see the little adhesive portions on the side, and this little bar is where you attach the tube to. Often we'll, especially men with a lot of facial hair, I was going to say women, but that probably wouldn't be the correct thing to say. Need to shave off whatever hair is there. And there's a substance called tincture of benzoin, which is a substance which makes the skin very adhesive and sticky. Try not to spill it on yourself. You'll regret it because it's sticky as hell, and it stings. But that you put a small amount of that on their skin if they're diaphoretic, and it will actually help to adhere the tape to the skin in the process. And this is talking about not only doing repositioning of the tube, but doing efficient oral care. We've gotten better in the last 15 years as far as doing oral care, but there was a time where if you were intubated, you rarely got your teeth brushed and your mouth cleared out, and it was just nasty. Now we've gotten, like I said, a whole lot more aware of it because it's one of the most common causes of nosocomial infection is microaspiration around the cuff of the endotracheal tube. So there's actually devices that are out there. This is kind of a unique one. This is, and I wish they weren't so expensive, but this is a Yankor that has a sheath that slides down or slides back up to protect it and keep it clean. What a great idea. I don't know what the cost comparison, but I got to imagine it's about 4 or 5 times the cost, yeah.
Is it nursing or is it respiratory? Typically,
Yes. Yes. Can you ever do too much oral care? No. In most places, it's probably nursing's responsibility, but if you're in there and you're suctioning out their endotracheal tube, pay attention to what's inside their mouth also. I don't know if it was, well, I won't go to the soapbox. Yes, in answer to the question. You agree, Nance?
It actually, as far as doing the oral care, it depends on which facility you're working at,
That's true.
as to who does the actual oral care and has to chart off on it. But as far as doing just oral,
It should be part of our responsibility too. Yeah. Males may be shaved, but use care not to cut the pilot balloon. This is a joke. There's this nursing assistant, Linda, and she sliced the cuff on the end of the tray, not the cuff, the pilot balloon, on a routine basis.
But every patient had the best shaved face.
That's right. That's right. She's a nice lady, but oh my God, not again. And this is just talking about the cost of a ventilator-associated pneumonia. I don't know why they call it a ventilator-associated pneumonia. It should be an endotracheal tube-associated pneumonia. Don't blame the damn ventilator. It didn't do anything. But the cuff being in place does end up, or the endotracheal tube being in place has a high incidence. And not only is the cost to the hospital increased significantly, but the morbidity and mortality goes up exponentially also. So one of the tubes that Mary will talk about is one that has the ability to continuously aspirate subglottic secretions. So secretions which are located in the hypopharynx above the cuff of the endotracheal tube. If there's a way that I can get those secretions out of there, I don't have the problem of aspiration. And this is just showing some of the biofilm that collects on the inside of the endotracheal tube. There's actually, have you seen that, Nance? Where they have the brush that goes down and actually that scrapes the inside off? Yeah, that's neat.
Yeah, it's really cool.
I don't want to show that. Extubating, pull the tube out when it's no longer needed for ventilation or oxygenation. No longer needed. So basically all the things that you would want to put a tube in for, when none of those things exist, pull it back out again. That's basically what it says. And that fourth bullet point, when medical care is deemed to be futile, there's a lot of times we'll do terminal weans, where we just extubate the patient, put them on some oxygen maybe, and wait it out. Go ahead. Oh, this is talking about the leak test. I think I got some slides on that. You want to assess their readiness, and a lot of times it's built into the protocol, especially on open heart patients. Kind of the similar equipment you want to have that is there. We want to have vapinephrin readily available in case they do end up having some laryngospasm following the extubation. And you always want to be prepared to re-intubate, so you want to have all your stuff that you would normally have to intubate the patient. We're going to go ahead and explain this to the patient, have them in a comfortable position, typically in a high Fowler's position. We'll suction the endotracheal tube, attempt to suction above the cuff if you can. We'll deflate the cuff, and basically do what's called an airway cuff leak test. And this is where I deflate the cuff, I occlude the tube, and I make sure that there's airflow around the tube. So you want to make sure that there's now swelling of the larynx to prevent, on extubation, the patient not being able to adequately ventilate. Okay? Now, if your patient looks like that, it's a very bad sign, because they're plastic. Once we go ahead and verify that there's adequate flow around the tube, and a lot of times people will auscultate and verify that also, we're going to go ahead and remove the tape, pass the suction catheter into the tube, have them take a deep breath. We want to make sure the vocal cords are open when that tube is coming back out again. So as they're taking a breath in, we go ahead and remove the tube at peak inspiration, and then they'll have the patient cough. They're going to cough on their own, trust me. That tube coming out is going to be a little bit of an irritant. So they're going to go ahead and clear their airway, verify that they're able to vocalize. Often we'll put them on some oxygen device and monitor with pulse oximetry, just post-extubation process. Should try to keep them NPO for a period of time, so that there's not any aspiration. It really depends upon how long they were intubated and what the overall health of the patient is. Some of the complications associated with extubation, like I mentioned, laryngospasm and laryngeal edema, subglottic edema, all kind of stuff can happen. Some of the things you want to make note of is how severe the stridor is. If they just have stridor and only mild distress, just some humidity and cool, moist, and some vaporephrine may be sufficient. As that degree of distress and stridor increases, you get to the point where you may need to resecure the airway again by reintubation. And again, just, is he ready to be extubated? Well, whatever was that he was intubated for, is that resolved? Does he have a good protection of the airway? Do the leak test? And can they manage their secretions? Okay, last part of this is that you will not only have to have the patient intubated, you're going to have to verify that the cuff pressure that is being utilized to secure the airway, to close off the airway, is the appropriate amount of pressure. So what we're trying to accomplish is basically a tracheal cuff pressure no greater than 20 torr or 25 centimeters of water, which should work out to someplace close to the same value. And you're going to see a little bit of variance involved with those numbers. These are the numbers that we will use for your PE, though. Okay, so you want at least a pressure. You want at most a pressure, let me rephrase that, of 20 torr or 25 centimeters of water. That's the pressure on the cuff, or the intracuff pressure. The theory is that that pressure is then the pressure that is transmitted across to the tracheal wall. We want to maintain arterial blood flow, and that usually is somewhere above 30. So pressures of greater than 30 on the will impede arterial blood flow, leading to ischemia. Greater than 20 will have a venous obstruction. Greater than 5 will have lymphatic. We'll live with the bottom two roughly, but we don't want the top one. We don't want to prevent arterial blood flow because that will lead to the necrosis of that tracheal and the potential for fistulas to develop. And this is why we use the kind of cuffs that we do. They're called high residual volume, low pressure cuffs, because they displace that pressure over a large area, so it's not one specific point. The old style cuffs had a higher pressure points where all the pressure was placed in a very narrow area, and that led to a higher degree of tracheal wall damage. So there's my cuff placed properly. The method we're going to prefer is known as the minimal occlusive volume. And this is based upon the relationship between the tube's inner diameter and the tracheal diameter. And we're going to need a manometer, a stopcock, and a syringe, or a cufflator, and we'll explain what those are as we go. There are other ways that we can look at. There's some special endotracheal tubes that have built-in pressure release mechanisms. I think Mary talks about the lands in the fall. There used to be, the minimal occlusive volume is the one that we typically use. That's a preferred method. So what we do is we go ahead and clear out the oral pharynx. We go ahead and inflate the cuff until there's no leak heard. We then deflate the cuff until we just hear a leak at that point. So auscultation with a syringe, you hear a little squeak of air leaking by as you're ventilating them. That means that there's a small leak present. We then inflate until that leak is just gone. So it's a minimal occlusive volume. It's the volume at which you minimally occlude the airway, okay, or seal the airway. Then we measure the cuff pressure that is utilized at that point. This is probably making no sense, but will make a lot of sense when we demonstrate it to you. So this is the system we're going to end up using, where we're using a three-way stopcock, which wherever this is pointing is off. So it can be off to the manometer, off to the cuff, or off to the syringe. I'm going to go ahead and attach. Where's my eraser? So we're going to go ahead and attach the manometer to the syringe. And what we're going to do is we're going to pressurize the manometer to our desired level. So let's say I want to keep it at 20 centimeters of water, better yet 25 centimeters of water. That's the pressure we want to have inside the cuff as a maximum, right? So I inflate, I push the plunger to syringe down until I pressurize this system. Got the idea of what I'm saying there? Okay. And this is then off to here when I'm doing that step. I then go ahead and attach my endotracheal tube pilot balloon. And I go ahead and I adjust this then so it's off to my syringe. Now what I'm doing is I'm measuring this pressure. This needle may drop up or down, hopefully down. If it continues to go up, that means that the pressure in the cuff is higher than my 25 that I desire. Now, if that was attained using minimal occlusive volume, ain't much I can do about it, right? That means that the tube is probably too small for that trachea because the cuff's got to be inflated large enough to seal it off. In that case, the suggestion is, hey, doc, I think we have too small of a tube here because I'm using a higher pressure, okay? If he chooses to leave it in and doesn't want to take it out for whatever reason, well, you document that and we're on our way. If it falls, if it's less than 25, well, that's cool. The reason why I pressurize it to start with is if I just hooked that pilot balloon up to my manometer and measured, that pressure within that cuff loses some of that volume of air to pressurize this dead space that is there. I don't know if that makes sense or not, but you're basically defeating yourself by just hooking it directly up. You need to pressurize that manometer first. Okay? Once you're done, then you just disconnect it and all is well. So turn it off to my patient, if you will. Verify that it rises back up. Go ahead then and close it off to the syringe. Measure my cuff pressure, whatever that value is, and we're okay. This is a device called a cuffilator, and it basically has a little stopcock attachment on the end there. And by squeezing the bulb, you can go ahead and inflate the cuff until you get the proper pressure that you desire in there, as read on the gauge. We have one of those, right? Yeah. For your PE, you'll be doing this method. Just warning. So if the required pressure is above the acceptable range, make sure that we got the tube in the right spot, that it's not too high, because a lot of times if it's too high in the trachea and actually into the cricoid cartilage, you'll get it'll require a lot of pressure to seal it. Make sure the cuff is functioning well. Deflate it, reflate it, try it again. And if not, try looking at a larger airway of some kind, either a larger size endotracheal tube or tracheostomy tube. Or in some cases, there's some specialized tracheostomy tubes that are longer in depth. That is there. So Mary in the fall is going to talk about a bunch of different kind of specialty tubes, a bunch of different specialty intubation adjuncts. The glide scope is a fiber optic tool that is way cool. There's all kind of stuff that is out there. Gum elastic bougies, which are a specialized tool to facilitate intubation in difficult to manage patients. So I think at page 43 is a lab, which would be lab 3. So for the balance of the day, what we'll do is let you work through those 3 labs, and the 2 PEs you should have enough, well, we've talked about. Now it's just a matter of you getting enough exposure of practicing. Open suction with sampling and endotracheal intubation with cup pressure monitoring. I'm sorry? That's four PEs, yeah. I'm sorry, did I say 2?
Yeah.
Well, the third one is that they can look at the closed suction, at least as far as that is concerned. We're gonna cover trach care tomorrow, and then trach care and closed suction are 1 PE together. Questions?
It's 59, 67, 64, 23.
Hut. Could be worse, right? We're doing okay? Yes, Alyssa.
Okay, as per our and
As per our what?
as per our
Quizzes, yes.
and whatnot, what do you suggest would be the best way to just go about studying?
Know everything.
Okay, fine, fair enough.
But the PowerPoint is,
I would follow the PowerPoints, yeah. Probably the best. Just the stuff at the end, the self-assessments.
Go like the information here first.
Yeah.